And now it would be my great pleasure again to introduce Dr. Shankar sir for the next topic. So again, as I have been saying this, we all know them for their great contribution to medical genetics in India. So Dr. Shankar sir is a professor, Department of Medical Genetics, SAT Hospital, Government Medical College, Thiruvananthapuram. He has 26 years of experience, teaching experience, and as an examiner, PhD guide. He has worked with WHO, National Polio Surveillance Project. He has started and is in charge of state-of-art genetic laboratory in the government sector, which is attached to the CDC Trivandrum. He's the nodal officer, COE, Rare Disease, GMC, Thiruvananthapuram. He's the principal investigator of many projects by ICMR, DHR, DBT. He has more than 60 publications, more than 10 textbooks. He's a reviewer for more than 5 international journals, and he has worked in the various capacity in the IEP district, state, and national level. And he's a founder and treasurer of Society for Indian Association for Medical Genetics. We welcome you, sir. Sir's topic would be management of Pompe disease and recent advances. The stage is all yours. Thank you, sir.
Thank you, Divanchana. I think I'm audible.
Yes, sir.
Okay. So at the outset, I thank Prasanna to give me the opportunity to talk on the Pompe disease on the auspicious day today, because it is International Pompe Disease Day. And this year, our slogan will be "Together We Are Strong." So I think probably there will be so many Pompe disease patient, affected parents and their relatives may be there. So always this rare disease community, including the doctors, pediatricians, Indian Academy of Pediatrics, Indian Academy of Medical Genetics, all COEs, government, all are with you. And together, we will go strong. So my topic is management of Pompe disease, because already my two colleagues, close colleagues, Ratna and Ashwin, has spoken about the clinical features and challenges followed by diagnosis. So I will be I will be go through the management of Pompe disease and some of the recent advances from the literature to know that what are the recent things are happening in the era of Pompe disease. Greetings from Thiruvananthapuram, Kerala, which is actually the apex medical college in Kerala, and we are one of the COE assigned by the central. So first two slides, just a nutshell, which already my colleagues, speakers have already described. Just for an introductory, directly not going to the management. As you know, Pompe disease is an acid maltase deficiency, or it's one of the glycogen storage disease. But only one glycogen storage is lysosomal storage disorder, which is an autosomal recessive disorder, deficiency of the lysosomal enzyme, acid alpha glucosidase, that's the enzyme deficient. And because of this enzyme deficiency, there is deposition in skeletal, cardiac, and smooth muscle. So multiple clinical features will be there. And usually it's a progressive disorder. There are two forms, infantile form and late onset form. Infantile form, rapidly progressive disease with cardiomegaly, hepatomegaly, hypotonia, and weakness. And untreated patients in natural history, most of them will death usually by 1 year. We have seen this in last 25 years. In first 10, 15 years of my practice, I have seen most of the Pompe disease are dying because there is no treatment is there. And late onset form is a heterogeneous group, presenting later with the predominant muscle involvement with mild cardiac involvement or may not be there. And potential misdiagnosis already Ashwin and Ratna, both of them detailed explain various differential diagnosis and some of the important points like family history, elevated CPK, hepatomegaly, elevated liver enzymes, and large tongue. These are, we will sell our pediatric postgraduates and 6-month-old with hypotonia when there is hepatomegaly, elevated enzymes, and large tongue. And always suspect Pompe disease, and cardiomyopathy with the short PR interval also will give more information. And diagnosis always by a DBT kit, which is easy, simple, and convenient for enzyme analysis, or you can do the from the serum or skin fibroblast. There are limitations which already Ashwini has told, and mutation analysis which will confirm the disease. I have gone through 3 slides to start the ball rolling. So coming to the management, I will just present one case which we are one of the case which we are managing with definitive treatment. So it's a 2-month-old presented with the cough and breathing difficulty. Mother also noticed weak cry since birth and feeding difficulty. Second child of non-consanguineous marriage. It was a term AGA 3.2 kg. So there is no immediate need-born risk factors. On evaluation, identified a cardiomegaly and a systolic murmur, and echo showed hypertrophic cardiomyopathy. So that itself is one of the key factor to suspect a Pompe disease. And the baby had a generalized hypotonia and reduced spontaneous movement and reduced deep tendon reflexes. And LFT shows transaminitis. And so second major marker for a Pompe disease, OT and PT is elevated, where OT is more elevated than PT, which is also suggestive of a metabolic myopathy associated liver problem. And tongue appears to be large, but no fasciculations. And in SMA, usually fasciculations will be there. Here, no fasciculations. Child was admitted in PICU, but these type children required a multidisciplinary care with a pediatric intensivist, cardiologist, and admitted in PICU, needed prolonged NIV support, and cardio myopathy team and cardiac team also started the drugs for cardiac failure, etc. Enzyme estimation showed a reduced alpha glucosidase in dried blood sport. So definitely we are directly go to mutation analysis, which shows a pathogenic homozygous variant in exon 14, which is the one of the hotspot for GBA gene. And one of the homozygous variant has been identified, which confirms the diagnosis of Pompe disease. So it is a classical simple case, which usually at 2 months of age, we diagnose the case. So what is the definitive therapy for Pompe disease? So in Pompe disease, nowadays we are having a definitive therapy, which is called enzyme replacement therapy, because already we have discussed some enzymes are low. Acid alpha glucosidase is low in the body, which is causing all these problems. But actually, these enzymes in the lysosomes are not formed in the lysosome. It is, as you know, all proteins are formed in the rough endoplasmic reticulum. So actually, inside the cell, it is formed in the rough endoplasmic reticulum, and from there, this is the rough endoplasmic reticulum. From there, it is transporting into the lysosome. And this transportation is basically by a method called the receptor dependent transport mechanism, where mannose 6-phosphate receptor is very, very important. So this identification by D. Dewey in 1964 called the secretion recapture pathway. That means enzyme is secreted in the endoplasmic reticulum, which is captured by the lysosomes inside the lysosome, engulfed into the lysosome, which understood that even if you give a parenteral, means out from outside the enzyme, if you give, most probably it may take it out. But at that time, there is no facility to have a artificially made enzyme. So first they have used the placental extract in 1991, 92 with Gaucher disease. But later, Gaucher also recombinant enzyme came. That's the first disease where enzyme replacement therapy found to be successful. And one of the another earliest disease is the Pompe disease. So Pompe disease, the enzyme replacement therapy started in 2006, approval in the FDA. And for the light onset form, the approval was given in 2010. It is actually a recombinant protein. That means it's not extracted from anywhere. It's a genetically engineered recombinant alpha glucosidase protein. That's called the A-glucosidase alpha, or trade name, because only one company is producing it. So I don't think there is any wrong in telling the name, myosin. And dose is 20 to 40 mg per kg is a standard dose. And intravenously it should be given. And once in 2 weeks, we have to give the infusion. And it has been proven that reduces the mortality in infantile form if started at the earliest. And there are so many studies which shows the effectiveness of the Pompe disease, not completely, but there are reasonably good effectiveness. And it has been given in the Cochrane database also. In 2017, Cochrane database, they have told enzyme replacement therapy for infantile onset Pompe disease. And one of the earliest trial of 18 patients with infantile onset disease who were treated with 20 or 40 mg per kg of enzyme given intravenously every 2 weeks. All of the 18 patients survived to age 18 months compared to one of 61 historic control. That's I told. Untreated patients, most of the time will die by around 1 to 30, 1 to 1.5 years maximum. And about in this group, most of the patients of the 18 patients have 18 months they have lived, and 13 had an improved motor function. So this is the first pre-licensure trial. After that, licensing has happened. And after that also, There are so many studies, so many clinical, case scenarios where it has been shown that there is a event-free survival. That means ICU admissions is reduced ICU admissions, and survival is improving, and motor function is improving in a little bit. And in this patient, we have started the enzyme replacement therapy by 4 months of age. Recombinant enzyme was given 20 international units per kg every 2 weeks, and other supportive management for cardiomyopathy and respiratory therapy as and when required was given. You can see that LV mass over time by 8 months itself, by 6 months it started long down. By around 8 months, it is significant reduced LV mass. Similarly, SGOT, PT also in between, there are some increases because the patient had a viral infection, pneumonia admitted, and otherwise, generally, the OTPT is also reasonably coming down. So this is the photograph of the patient. By around 8 months or 9 months, child had a significant improvement in the motor function. Child can move his upper limbs, child can use the lower limbs, and you can see that how she is better in around 1.5 years of age. But what are the adverse effects of ERT? Once very few patients may have a severe hypersensitivity reactions, but we have to always look for the hypersensitivity reaction like rash, itching, and even shock and other which require adrenaline and other things. But most of the time it will be treatable with steroid and antihistamines. And acute cardiorespiratory failure is another problem which is seen, especially in Pompe disease, because already they are having a cardiomyopathy. And first few doses, you have to be very careful. Slow try infusion as a dose they have escalating, slowly escalating doses like 3 ml per kg per hour, 8 ml per kg per hour, 13 ml per hour, and 18 ml per hour. That slow titration should be properly done because there is a possibility of acute cardiorespiratory failure because of the volume overload as well as the immediate enzyme body reactions. Then infusion reactions. Then another major chronic problem is the antibody formation, which I will come to that later when I am discussing about the CRIP. So these are the major adverse effects of the ERT. But along with the ERT, always the multidisciplinary care is very, very important for patients with Pompe disease because they may require physical medicine, rehabilitation, cardiology, pulmonology, orthopedics, nutrition, physical, occupational, and speech therapy because it's a chronic disorder. Even if you give ERT, everything will not be in a routine way. They may require in between ICU admissions, they may require respiratory support, they may require in between pediatric pulmonology admissions, then older patients will require the a regular lung function test, so many other things already we have discussed. So multidisciplinary care should be part of the treatment. And light onset Pompe disease, LOPD, here also enzyme replacement therapy can be definitely has been recommended and it's proven to be benefited. And ERT improved the walking distance measured by 6-minute walk test. ERT improved pulmonary function by lung function test. And ERT has shown definitely improvement in survival, fatigue, quality of life, participation in activity of daily living, gastrointestinal symptoms in observation studies. So definitely LOPD also ERT is recommended. But only one major problem because this ERT we are giving regularly when this COE, Center of Excellence Rare Disease Policy came, and we were able to support the most of the some of the patients with the Pompe disease. But light onset Pompe disease still it is not under the realm of management because here sustainability is a major issue because 1 year treatment for this LOPD for an adult 50 kg patient somewhere around 2.5 crores will be required. So it's a very costly affair. So LOPD treatment is still not under the it's not easy to give it. IOPD we can try to certain extent so that at least 1.5 to 2 years of treatment may be able to do it in 50 lakhs and rest we can do with some other options and charitable access, etc. And about the long-term survivors, there are so many literatures are there. ERT reverses cardiomyopathy and global function, but still present risk for arrhythmia because they have told in a long studies, 5 years, 10 years, etc. They have shown that cardiomyopathy is reasonably improving. I told our patient also, both two patients we have regularly were given, regularly they are having a significant improvement in the cardiac function, but risk of arrhythmia, they told not totally there is a risk. ERT improves motor function, but without incomplete correction of skeletal muscles and accumulation of glycogen in CNS leading to symptoms like hypernasal speech. So they told most of the long-term survivors have some quality of speech tone is different. And high antibody formation to the GI, especially in CRIM negative patients, is another major problem. So long-term survivors exhibited sustained improvements in cardiac parameters and gross motor function, residual muscle weakness, hearing loss, risk of arrhythmia, hypernasal speech and dysphagia, and risk of aspiration and osteopenia were commonly observed. Because this article is specifically telling, since we have started this enzyme replacement therapy throughout the world for so many patients, so there is a subset of group of survived Pompe, where so many other new symptoms and new complications, which we have not seen in these other patients, may develop, and it is a this also we are seeing in our experience also. Now coming to the CRIM status, because I told the CRIM negative patients have a poor responders for enzyme. So what is this CRIM? CRIM is a cross-reactive immunological material status. That is the short form. What do you mean by CRIM negative? CRIM negative means lacking any residual GAA expression in the body. That means in a patient when some specific mutation, there is absolutely no GAA protein. Those patients, even a single dose of this recombinant enzyme will act as a foreign material and high quantity of antibody will be produced. That antibody will immediately reactivate the enzyme so that even if you give the ERT in a sufficient dose, the effect may not be that much good. So with negative CRIM status associated with the poorer responses to ERT and worse prognosis. And previously we used to measure this CRIM status by various methods. I'm still remembering in 2007, 2008, 9, 10, up to 12, 13 when we are giving this enzyme through the charitable access scheme, we used to send the blood sample for identifying CRIM status and other things. But now, since we are doing the NGS results we are available, we can easily look at the databases to look for the CRIM status because most of this mutation, the CRIM status is available by mutation. And specifically told that the CRIM negative patient, that is an introspective analysis of 32 patients who were treated with the ERT, CRIM negative status was associated with an increased risk of death or invasive ventilation after 52 weeks of therapy. And it's very different, 54.5 against a 4.8% in CRIM positive patients. So CRIM status is one of the important factors which will determine the ERT response. In another study of 11 patients, higher antibody titer was associated with a poor response. So both are related actually. CRIM status and antibody formation is related. This is one of the database which shows the CRIM negative mutations. You can see that one of the common mutations which we see in our part C.1A2G exon 2, which is actually a CRIM negative mutation. That may be the reason our patients, all patients, we are not getting a good response. And what we can do this for CRIM? For CRIM or antibody formation, there is an immune tolerance induction. That means we are teaching the body to accept this foreign body as own. That means we are controlling the immune regulation of the body or immune action of the body so that it will not reject the foreign body. That's naturally true with the rituximab. There are so many regimes are there, but most tried regime is the rituximab with a low or high dose of methotrexate with and without immunoglobulin. Because rituximab is mainly humoral antibody. C19 cells will be C19, C20 cells will be totally suppressed so that there is a high chance of immunosuppression. There is a possibility of infections. So during that period, when there is a count, the CDC19 and CD20 cells will be reduced, we have to do immunoglobulin IVIG in every month. So this immune tolerance regime with rituximab plus methotrexate has been tried, and it has been shown that these patients who are treated with the immune tolerance plus a glucosidase, the chance of developing antibodies are less. They have tolerated this glucosidase ERT in a better way. But this rituximab, as you know, it's a very little bit risky thing. So in another series, few patients have got induced B cell depletion, complete B cell depletion, which causes a lot of problems. And actually, it is still the effects of IT are still under investigation and do not always lead to improved outcomes. But nowadays, people are using as a isolated methotrexate only, low dose methotrexate regime. That is why we are also using in some of our patients. Transient low dose methotrexate used at the initiation of therapy. So are encouraging the cells. That means methotrexate alone dose may not have that much immunosuppression, whereas rituximab plus methotrexate will have a significant immunosuppression. So this is just to complete that trim area. I have included this into these slides. And another important thing during Dr. Ratna has told about the urine glucose tetrasaccharide, which is a biomarker and which is elevated in patients with infantile onset but not late onset GI deficiency. So it is the one biomarker which will help you to differentiate these two, but that is not mandatory for the diagnosis. But during the treatment, it is always better to follow up through this urine glucose tetrasaccharide, which is definitely one of the marker which shows that treatment and efficacy, how it occurs. So, but it is not routinely available in our setup. So practically we are not using it regularly. But previously, I still remembering through when we are getting through the charitable access under the guidance of Priya Krishnani. At that time, we used to send the urine for urine glucose tetrasaccharide to ES. But now we are giving through our COE, and routinely this is not available regularly in our part. We are not doing it regularly for all patients. And already we have discussed, Ashwini has told, diagnosed, Madam has told, the Madam has told, early identification is very important because administration of ERT at 18 hours of age resulted in normalization of cardiac abnormalities within 21 weeks of therapy. That means if you treat it early, this cardiac can be totally reversible and normal neurodevelopmental assessment at 46 weeks using Griffith. This was around 2008, one of the earliest single case reports which shows that early treatment is working. With that, there is a large study from Taiwan where they have done the newborn screening in 6 lakh, I think 6 lakh 69,797 newborns, identified 14 newborns where they have started ERT on 11 days, 11.92 days, and result is most of the people will have a significant improvement and they are having say, there is no cardiological problem. And the mean age for independent walking was 11 plus 6 plus or minus 1.3 months, the same age of normal children. So that means they are having a normal walking, normal motor milestones, as well as their cardiac, nothing has happened. So it shows that early treatment will have a significant response in Pompe disease. So if you diagnose it early, if you start it early, there is a better response will be there. That is the situation where this newborn screening came, and some of the countries like Taiwan and some of the countries in the states, in the United States, also started the newborn screening with infantile Pompe disease, which will have an early detection and identification of the condition by newborn screening, and initiation of therapy before 1 month improves the response rate. And Taiwan experience shows ventilator-free survival of 100% of patients. So it is having some role, but I am definitely know that is not the situation in our country where we will start newborn screening directly, venture into that. But in the future, once the treatment is available to everybody, we will have a universal treatment for IOPD, newborn screening. We have to think about the newborn screening for early detection so that prognosis will be better. And still advancing thing, recently in 2023, prenatal diagnosis, Priya Krishnani and other groups, there were intrauterine enzyme replacement therapies for lysosomal storage disorders, including Pompe disease, and current developments and promising future prospects. Because we know that once cardiomyopathy is significantly gone into a level that cannot be totally cured. So intrauterine enzyme identified a diagnosis in the prenatal period by prenatal diagnosis and give intrauterine enzyme replacement therapy, which may have a benefit or a good prognosis if you start. These are some of the recent developments here. And about the enzyme, there are two new enzymes has also been, we cannot say new because it is a approved thing in the FDA and Western countries. One is the next viazine, which is a aval glucoside is alpha. One, I'm sorry for the spelling mistake, it's ABAL, one L has been lost. It's an exogenous source of the enzyme. Same is a recombinant enzyme, but only thing is mannose 6-phosphate receptor binding has been improved by some technology. M6P receptors on the cell surface with high affinity. Already I told you, when it is going from the rough endoplasmic reticulum into lysosome, this M6P receptor is important. So this M6P receptor affinity has been increased for these molecules so that the uptake to the lysosomes will be better. So that definitely there is a better improvement will be there. But as a preliminary thing, it has been approved only for the more than 1 year old children and adolescents with a non-classical as well as in the light onset Pompe disease. Less than 30 kg is a 40 mg per kg per dose every 2 weeks. More than 30 kg is 20 mg per kg per dose every 2 weeks. And some of our charitable access scheme also, I think Sanofi has changed this next by as the treatment of choice. And another thing is a glucosidase alpha, which is a recombinant human acid alpha glucosidase formulation in combination with the miglustat, an enzyme stabilizer that reduces inactivation of ERT. It's a USA approved, adults with more than 40 kg. It is only approved in 2023. That is why now it is approved only for the adults with the light onset. And it has to be given 20 mg per kg infusion over 4 hours every other week. Begin infusion 1 hour after miglustat dose so that it is a miglustat, so that it is having a, what you can say, the enzyme will be more stabilized so that it will have a more effect. These are the two important things came in the advancement technology in the slide. What are the therapies under research? As usual, any genetic disorder, gene therapy has also been tried. And here also adeno-associated AAV9 vector, recombinant adeno-associated virus vector with alpha glucosidase has been tried. That is under study and some studies are going on that. And under alternative forms of ERT with improved cellular mannose-6-phosphate, phosphate uptake and lysosomal trafficking for a better uptake. And moderate intensity exercise with the high protein diet in some late onset diseases that people have tried, and diaphragm pacing with the graded inspiratory muscles exercise. Because some group have tried other modalities of treatment also, especially light onset disease, where immediate survival is not an issue. How to maintain their respiratory complications as well as the muscle function is more important. Other mechanisms also been tried. Thank you very much for patient listening. So I have gone through some of the important aspects of management of disorders, enzyme replacement therapy, and some of the recent advances. Any question is there? I will try to answer.
Thank you so much, sir, for such a wonderful talk and such a precise, comprehensive overview on the management which is present over here. We have actually several questions related to it, but we'll take it at the end of the session. I thank you once again, and I take pleasure again to invite Dr. Gauri Krishnan ma'am for our next talk, which is a very interesting talk on basically does ketogenic diet works for Pompe's disease. I had first time heard this in one of the conferences in SSIEM, and it actually intrigued me a lot with the data. And so when we decided to have an awareness a webinar on this topic, I felt that this should be a topic of discussion in India as well. I welcome Dr. Gauri Krishna, ma'am. Ma'am currently is a visiting consultant with Rainbow Hospital, Cloud9, and Baptist Hospital. She's visiting professor and is a leading PI for various sort of topics like PKU, XLH rickets, MPS, AADC. She has various publications in JIMD, Human Molecular Genetics, JB, MR. She has several awards to her name, and we welcome ma'am for this particular talk over here. And ma'am, again, the webinar is all yours. Thank you, ma'am.
Thanks, Dipanjana. Can you see my screen?
Yes, ma'am.
Okay, so apologies, I'm actually in traffic. I underestimated my travel time back home. So I'm stuck in traffic and it's Bangalore, so apologies about that. So if you lose me at some point, I did try. So I'd first of all like to thank Mr. Prasanna for organizing this very important day, because I think lots of families with rare disorders feel isolated. So do clinicians. So it's really nice to have spaces like this where we can discuss, get to know more. And I've had a very interesting educational session as well. What I'm going to talk about is obviously slightly different from what the previous speakers have been talking about in terms of how we are going to look at this particular disease as a whole. And one of the things I obviously feel is different, having trained elsewhere, is the sort of support, ancillary care, nutrition, respiratory, physiotherapy. It's all fragmented. And I think lots of people start things without really understanding quite a bit, mainly because everybody is really trying to find a solution, and I completely appreciate that. I might switch off my audio in case, I'm trying to, it's all on 5G, so if I lose it, so it might do that just so that I can persevere with the talk without losing internet. So let me just start off with today's session. So one of the things that I wanted to discuss is why this question matters now, and also talk about with the ketogenic diet, why we're looking at a two-hit model within the pathophysiology of Pompe disease. And we want to make both a biological case for ketogenic diet and also look if there's evidence against it, because we want to have a very rational, evidence-based approach to something that is novel and upcoming at this point in time. We also want to look at emerging alternatives within the nutritional space, and look at doing some practical guidance and clinical recommendations. And at the end, also looking at what we want to tell our patients with the information we have. So why this question matters, because patients are doing it. Patient communities and forums are actively discussing and adopting ketogenic diets with or without clinical guidance. And this is happening whether we engage or not. And that's why it's critical we answer this question with as much honesty as possible. Researchers are also watching. I think the Tanpolowski group, as well as the Agostino group, as well as Mayo Clinic, are actively investigating ketogenic diet in Pompe patients. And this field is moving quite actively. So what we want to understand is there enough evidence? At the moment, no randomized controlled clinical trials exist, and clinicians are being asked about something that there's limited guidance about. So we must be very honest about what we know and what we don't know. So first and foremost, let's understand the pathophysiology of disease and why ketogenic diet may or may not work within the context of the pathophysiology. So one of the things is, we know of already all these speakers have spoken about lysosomal glycogen accumulation. So that's your primary hit. So you've got GA deficiency and glycogen cannot be cleared from lysosomes. You have swollen lysosomes which expand, rupture, and damage surrounding tissue. There's cardiac, respiratory, and skeletal muscle involvement. And the ERT targets this hit and works really well in the cardiac muscle, but less so in skeletal muscle. The second hit, which is the autophagic block. So autophagy is a way of cell death, so how our body takes care of cell death. And there is a significant autophagic flux failure in the autophagosomes, which accumulate in your type 2 fast twitch fibers. So this disrupts contractile apparatus, so your, how the muscle pumps, and causing a ERT-resistant skeletal muscle decline. So that's something really important to understand. So this acts as sink for ERT. An enzyme is diverted from lysosomes into autophagic vacuoles. And this is fundamentally why skeletal muscle is ERT resistant. So let's look at the evidence supporting ketogenic diet in Pompe disease. So basically what we are thinking about is, within the context of the two hits, what are the things we can do and how will ketogenic diet help within that two-hit hypothesis? So first and foremost, we're looking at substrate reduction. So reduced carbohydrate intake, because we know that ketogenic diet is a low carbohydrate or absent or minimal carbohydrate intake. So reduced carbohydrate intake, there's less glucose available for glycogen synthesis via glycogen synthase. There's lower lysosomal burden, and that's the same logic as you get for the pharmaceutical substrate reduction therapy, which is now in phase 2 trials. The next one we're talking about is the autophagy induction. So what they have demonstrated in the study done in 2005 was that beta-hydroxybutyrate stimulates chaperone-mediated autophagy. So if autophagic flux can be restored, both cellular housekeeping and ERT delivery to lysosomes improve. The third one, and this is also interesting because within the whole ketogenic diet, there's a lot of anti-inflammatory talk. All of this is part of what has been going on since 2015. So the beta-hydroxybutyrate inhibits the NLRP3 inflammasome. And as a HTAC inhibitor, BHB also protects against oxidative stress, which is a major driver of secondary pathology in Pompe myopathy. Finally, the mitochondria has to figure everywhere. It is it is the energy powerhouse of cell, and it features in almost every sort of skeletal or cardiac muscle or any muscle issue. We always talk about mitochondria. So mitochondrial support, we know that Pompe disease, like a knock-on effect, does cause a degree of mitochondrial dysfunction, and ketone bodies are highly efficient mitochondrial fuel. It bypasses impaired glycolytic pathway and reduces the mitochondrial reactive oxygen species production. So that's really important to think about. In summary, we were looking at 4 specific targets: the substrate reduction, autophagy induction, anti-inflammatory signaling, and mitochondrial support. So the key supporting evidence comes from this 2022 paper from the molecular from this particular paper from Molecular Genetic Metabolism, where they've looked at ERT alone, ERT with ketogenic diet, ERT with beta-hydroxybutyrate, ERT with beta-hydroxybutyrate, and antioxidants. So if you see the gradation over the period of time, it's ERT alone, baseline, so there's partial benefit. Type 2 fast twitch fibers remain resistant. The autophagic backlog which persists, and it's a benchmark comparator because that's what started off even within the sort of historical catalog of how Pompe disease treatment has evolved. Then we looked at moderate benefits, so ERT plus ketogenic diet. So ketosis has been achieved. The autophagy does improve, and that is better than ERT alone. The glycogen load is reduced, and type 2 fiber still, the function is not fully preserved. Then we look at a slight superior sort of grade when we look at these studies. This is superior to both ERT alone and ERT with KD, which is when we add the ketone bodies. So there's attenuated autophagic buildup, preserved muscle strength, and motor function. And then finally, the best sort of results that they demonstrated in this paper, the ERT, the ketone bodies and antioxidants, normalized mitochondrial protein expression, greatest autophagy clearance, and lowest oxidative stress. So the key finding here is that ketogenic diet does provide benefit versus ERT alone, but is inferior to ketone precursor supplementation. The diet may not be the optimal vehicle. So let's look at the clinical evidence with high protein, low carbohydrate diet in late onset Pompe disease as well. So this was from the Italian crossover RCT, where they looked at exercise with high protein diet in 13 LOPD patients on ERT, where they demonstrated, so there was a 25 to 30% protein, 30 to 35% carbohydrate, 35 to 40% fat, and the total number was 13. Obviously, it's not a large number, but that's a problem with clinical trial design in rare disorders in any case. So there was an improvement in peak aerobic power. So there was which decreased in the control period, significantly increased after exercise plus high protein diet combination. The muscle enzyme level, CK and LDH, significantly reduced after exercise plus diet versus exercise alone, suggesting less ongoing muscle damage. The quality of life, where they looked at SF36 score, significantly improved versus control period. Patient-reported outcomes supported the functional gains and better pulmonary function test. There was improved lung function metrics in exercise plus diet arm versus exercise alone in the control. So this is a high protein, reduced carbohydrate diet, not a classic ketogenic diet. That's important to remember. And the conflation between the two is a major source of clinical confusion. So very often they're used interchangeably and they shouldn't be. And that's really, this distinction is important to make. So what is the evidence against KD? So that we have a balanced view and that we are neither doing too much or too less. So this is really important because the risks are real and it's clinically important. So the most important safety concerns is skeletal muscle catabolism. So the KD may actively worsen fast twitch type 2 muscle fibers, the very cells most damaged by the Pompe disease. So the ketone body upregulates muscle atrophy genes, the MAF1, MAFBX, and FOXO3. The KD suppresses insulin signaling and IGF-1, which reduces the anabolic drive on skeletal muscle. The KD also inhibits the mTOR pathway, which is the mammalian target of rapamycin, which is associated with your autophagic signals and flux, and that blunts muscle protein synthesis directly. You also have gluconeogenic demands, recruit amino acids from muscle. So there's a net catabolic state even with adequate intake. And the fast twitch type 2 fibers are more sensitive to starvation mimicking catabolism than slow twitch fibers. So this is the paradox. KD may stimulate autophagy signaling while simultaneously accelerating proteolytic destruction of already vulnerable type 2 muscle fibers, which potentially worsens the very tissue it's aiming to help. So let's just look at the evidence-based arguments against classic KD. So KD inferior to ketone precursors in the best preclinical study done by Nielsen in 20. Autophagy induction, which is the autophagic paradox that we
Hello, ma'am. Uh,
Ma'am, I think network issue.
yes, can we just call ma'am once
Yes,
so
yes,
that,
yes, ma'am.
yeah, thank you.
and poor long-term adherence, compounding existing
Yes.
vulnerabilities.
Excuse
So
me,
no
ma'am.
art.
Ma'am, sorry, ma'am. We lost you for about 1 minute back. So if you can please repeat that part.
Did you? Am I back on?
You are back on, ma'am. But for the last about 40 seconds, we couldn't hear you.
Okay, so should I just quickly summarize the 5 evidence-based again?
Yes, yes, ma'am, please.
Let me just do that. So basically, we were looking at KD being inferior to ketones, and it is really important to understand. Right, let me just switch on my camera because I'm back home. Might as well do it correctly now. Just 1 second.
Yes.
Okay, it's not working. Let me just go back. Okay, so the 5 evidence-based arguments against classic KD. So we've looked at ketone precursors being better than KD. So this was a preclinical study done by Nielsen and in 2022, where the ERT plus KD was outperformed with ERT with ketone bodies for muscle strength, autophagy clearance, and oxidative stress. So at the end of the day, why are we prescribing the inferior option then? But saying that, we also need to discuss about ketone bodies availability in India, which we will do a bit later. And then we're looking at the autophagic paradox. Most autophagy induction without improving lysosomal clearance capacity could worsen the autophagic backlog. The problem in Pompe is a failed flux, not a failed induction. And this distinction is really important. And then we look at protein restriction risk. Classic KD is a moderate protein intake problem. So Pompe patients need very high protein, between 1.5 to 2 grams per kilogram per day. Protein restriction in a muscle wasting disease is directly counterproductive to the therapeutic goal. Also, when we look at nutritional undernutrition risk, LOPD patients often have borderline nutritional status. KD adds risk of micronutrient deficiency, undesirable lean mass loss, and poor long-term adherence, compounding existing vulnerabilities. And also, we don't have any RCT data. So zero randomized control trials.
Sorry, ma'am, to intervene, ma'am. Your slides are also not visible. Can you please again, if you could just show the slides if you are showing slides, we can't see it.
Okay, wait, so just bear with me a second. Let's.
Sure, ma'am. Yep, ma'am, you're back on.
Yeah, I'm back on. Okay,
Yeah.
just let me put this. Right, so this was where we were. So that's just summarizing it. And then if we go on to what we want to discuss now. So we've had a for and against for ketogenic diet. So the better path is the ketone precursor and multi-ingredient sort of co-therapy, and why the supplement strategy outperforms the dietary strategy. That's what we're trying to also discuss. All right, let me just start my video. I can do it now. Good. Okay. So when we're looking at ketone precursors, we're saying that it achieves some ketosis without dietary restriction. And doing diet very often in children with chronic disorders can be challenging. There's no protein restriction needed, so there's high protein is maintained. Superior autophagic clearance in knockout mice in GAA, with GAA knockout mice, better preservation of muscle strength and motor function, and it is synergistic with multi-ingredient antioxidant cocktail, and it is tolerated in healthy adults, which is, for the safety data. So from that perspective, the ketone precursors seem to be a better outcome than the classic ketogenic diet. So the multi-ingredient adjunct, so we're trying to target all the pathological mechanisms so that we have the best outcome. And this was again from the Nielsen paper, where we're looking at ketone precursors, anti-catabolic compounds, antioxidants, energy carrier, antioxidants again with alpha lipoic acid, amino acid with citrulline, and vitamin E. So these compounds together seems to have the best outcome because it's targeting every different aspect which is involved in the pathology of Pompe disease. So the ketone precursor, we've already discussed how without full dietary restriction, it stimulates chaperone-mediated autophagy and provides alternative mitochondrial fuel. The HMB, which is anti-catabolic, it preserves lean mass and directly counters the atrophy risk of ketotic states. The CoQ10 restores mitochondrial complex activity, reduces reactive oxygen species that accumulate due to lysosomal autophagic stress in Pompe myopathy. Creatine, we've got a very well-established safety profile. I think everybody's on creatine these days, which enhances phosphocreatine resynthesis, supporting ATP availability in metabolically stressed muscle fibers. The alpha lipoic acid is both water and lipid soluble, so it's got a unique capacity to regenerate other antioxidants like C, E, and glutathione. It also reduces advanced glycation end products, which is really important within the context of skeletal muscle metabolism. Citrulline stimulates nitric oxide synthase, improving muscle perfusion. Also upregulates, again, I said, mammalian target of rapamycin, independent protein synthesis pathways, which is critical for Pompe. Vitamin E, fat-soluble antioxidants protecting cell membranes from ROS-driven lipid peroxidation, particularly important in the mitochondria-rich type 1 fibers. So we look at the practical clinical guidelines, what we want to tell our patients today and how to monitor those already on KD. So first and foremost, we want to look at the verdict and key evidence in order to decide what we want to do. So we have a substrate reduction rationale. So there is a strong verdict for it where you have, we know that it reduces glycogen precursor, same mechanism that we see with the substrates in the phase 2 trials. The autophagy induction, there's mixed, or KD induces autophagy, but there is flux failure, not induction failure. And that flux, the induction failure is the pathological problem in Pompe, not the flux failure. And ketogenic diet addresses the flux failure, which is not very useful. And then we look at preclinical benefit versus ERT alone. But we do know that ketogenic diet plus ERT is better than ERT alone, especially in the GAA knockout mice done in the study in 2022. So there is a real benefit, so we can definitely discuss it with our patients. But if we do KD versus ketone precursors, KD is inferior and the diet may not be the optimal delivery vehicle. The type 2 muscle safety, again, it's against it because the significant catabolism risk in the most affected fibers, it's all blunted with just doing ketogenic diet. The clinical RCT evidence in Pompe, none. We have no RCTs. And then we look at high protein, low carbohydrate diet, which is different to the classical ketogenic diet. That has demonstrated functional benefit in late onset Pompe disease. But again, this is not a classic 4:1 ketogenic diet. Again, adherence and nutrition safety. KD is very difficult to sustain. We know that there could be risk of protein and micronutrient deficiency in already nutritional vulnerable patients. So 6 clinical recommendations. So we would recommend a high protein, low GI diet, not a classic KD. Target 1.5 to 2 grams per kilogram per day. Reduce glycemic load, avoid protein restriction, and this has the best clinical evidence base. Not routinely recommend the classic 4:1 ketogenic diet. There's no RCT evidence, real risk of fast twitch muscle catabolism. Patient may be trading a theoretical benefit for an actual harm. Monitor patients already on KD carefully. So they need all of the DEXAs for lean mass when they're older, 6 months, 6-minute walk test if they are mobile, pulmonary function, nutritional markers. And we don't reflexively stop if they report benefit, but we do track it. We watch ketone precursor supplementation data. So we look at the ketone precursors with antioxidant co-therapy, which is the most promising direction from preclinical data. Safety data in the healthy adults is really encouraging. We combine nutrition with aerobic exercise training, which has the most consistent evidence for improving the mitochondrial lysosomal axis, and don't treat diet in isolation. Screen and correct nutritional deficiencies. So we regularly check vitamin D, B12, protein intake, bone mineral density, especially with late onset Pompe disease. This is quite suboptimal, and correcting these alone may improve symptoms with ERT response. So what should we tell our patients when they ask us about the ketogenic diet? So you validate the instinct. Yes, the instinct is right because it makes sense from a biological perspective, especially in Pompe disease. Reducing glycogen substrate makes scientific sense, and researchers are actively investigating this. But the classic keto diet, high fat, moderate protein, is not the right tool. You need protein to protect your muscle. The keto diet, as classically defined, restricts protein. We give the right and real evidence, what the research actually supports, which is high protein, lower carbohydrate, low glycemic index diet combined with aerobic exercise, not the 4:1 ketogenic ratio. And we keep the door open always with anything in rare disorders or even in medicine, that we're looking at exciting research, which is ketone supplements, not the full diet, which may give you the metabolic benefits without the muscle protein risk. And this is still being studied actively. And we have to be honest, duty of candor is really important within treating long-term chronic illnesses which require intensive support. There are no clinical trials of the classic keto diet in Pompe disease specifically, so we can't promise any benefit, but we can help optimize nutrition safely and with what we do know. Okay, so the treatment pipeline validates the KD hypothesis. So the sort of pharmaceutical world is also moving in the direction of KD hypothesis points, but with targeted agents. So you've got next-gen ART, which is approved, reduces autophagic buildup more effectively than alpha-glucosidase alpha, and targets HIT2 by improving ERT delivery past the autophagic sink that we've already discussed. Phase 2, we are also looking in 2026, the oral glycogen synthase 1 inhibitor as an add-on to ERT, which is a pharmaceutical substrate reduction, the KD rationale in a sort of pill form, which is enrolled, the enrollments begin in March 2026. There's phase 1B of novel substrate reduction therapy targeting glycogen synthesis, which is RNAi-based approach, which is a sustained effort without dietary adherence burden. And for preclinical, we have the nutritional ketone precursor, along with multi-ingredient antioxidants, which has been demonstrated to be superior to KD in the GAA knockout mice. So human safety data is still emerging, but it is sort of the most relevant thing within our what we want to talk about today. So these were my key references for the talk this evening. So the honest answer is Pompe disease gave us lysosomal biology, and there's been extensive work that has happened. KD question is not fringe. It speaks directly to the disease's pathophysiology. The KD is rationale is very sound. The signal is real, but the dietary KD is probably the wrong vehicle. The future is targeted ketone supplementation as adjunct to ERT, plus next generation substrate reduction therapies. And I would recommend high protein, low GI diet with aerobic exercise and optimized ERT. And we just watched the pipeline. So that was it. Thank you. And I'd happy to take any questions.
Thank you so much, ma'am, for such a wonderful talk and such a wonderful, actually, I would say, debate for and against making a case out of the entire nutritional management of Pompe's disease. At the same time, we do have a lot of questions on the like our question answer box, and these questions are targeted to everyone in the panel. So I'll start one by one. So there are some questions which have been from the patients. In fact, there are quite a few which is directly from the patients, and one from Dr. Eshan. So I'll take his question first, and this is probably directed to Dr. Ashwin sir. So he asks, in the prenatal setting, if a discrepancy is observed between biochemical assay, example low, and a molecular testing where a heterozygous variant has only been identified and a second variant has not been identified, how to counsel about the pregnancy outcome in the case? Ashwin sir, would you answer that, or and then we can go around with all the senior other faculties. So, Ashwin sir, are you there? Sir is probably not there. So, in Ratna ma'am, Shankar sir, anyone wants to take up? Gauri ma'am, anyone wants to take up this question?
Sorry, could you just repeat the question, Deepanjana? I sort of missed it because my audio's cut out.
Yeah. So basically, the question is that this is a question by Dr. Eshan. He says that the enzyme assay is low, but there is only one variant found genotypically. How to counsel this patient for pregnancy? So it's basically that we have found only one variant, but the enzyme activity is low. So in that sense, how if the person wants to conceive again, how do we go about it?
So Ratna, I'll just take it and then we can have comments by the others.
Yes.
We have to define what low means, okay, and the methodology that has been used in the laboratory, as well as what are the standards, all right? Because if it is amniotic fluid, is it cultured? Does the laboratory have control? Because enzyme testing in a prenatal sample is very, very specific. If it's done in a CVS sample, then what are the, controls there? And sometimes if you have heterozygous carriers, the enzyme can be borderline low. So I would go into all the quality issues, what are the controls, etc., before I can give a final decision.
Ma'am, here I would also like to ask you, and comments by all others. So we know that in these cases there are certain pseudo deficiency alleles, so which can have low enzyme activity, but there is no clinical phenotype.
But so all that would have been sorted out before a prenatal.
Yes.
You'll only do a prenatal after those.
I'm saying independent of the prenatal thing. Like, sometimes when you have sent it for an enzyme assay and it comes out low, but there is no other clinical phenotype, or there is one allele and you have sent it as a reflex to for biochemical testing. Like if it's a pseudo deficient allele, and will you, if it's a low enzyme, would you look into further, or if there is no clinical phenotype, we actually don't probe more? Like if it's a VOUS, some pseudo deficient we know, but if it's a VOUS.
So what there is what's important to understand is you're doing a prenatal test. What was the indication?
Yeah.
So if it's a previous affected, all this should have been sorted out. Yeah. If it's a carrier, then you would have to have pathogenic and likely pathogenic variants based on which a PND is done. Okay, you'll have to go into those details. But yes, if on a random sequencing, you get it as a incidental finding, there are these pseudo deficiency alleles and we evaluate for that. And if there's no phenotype, then we don't do anything. But of course, we have to take the age of the child and do a thorough evaluation if it's not one of the known pseudo deficiency. alleles.
Thank you, ma'am. Sir, any comments? Shankar sir, any comments? Gauri ma'am, any comments?
Oh, actually, Ratna has answered.
Sir, you are not audible, sir. I think
Okay,
it's echoing. So it's echoing,
echoing.
sir. You are, yeah, you are
Okay, can you
probably
please answer?
in two.
I will check it out. And same as Ratna already explained.
Sir is not visible. Gauri ma'am, would you like to comment in between? And then when we have sir back, sir can continue.
I think I just agree with Dr. Ratna. It's there's a whole framework where we look at pseudodeficiency risk figures and natural history, and then based on that, with investigations, we decide what is the best route in terms of investigating the unborn fetus and counseling for parents. So there's a clear pseudodeficiency framework already outlined, and I think it's available online. So there's nothing extra to add from what Dr. Ratna said.
Okay, thank you, ma'am. When sir comes back, I guess sir can answer the question, but we'll go back to the other questions that we have. So we have a question here from Mahesh Babu. He says that what tests to be done on a regular basis for a LOPD patient who is supported by a BiPAP machine, and what diet to be followed for a better health?
Sorry, I didn't hear that.
Ma'am,
Diet, there's been such an extensive talk, so maybe Dr. Gauri can take that question. And patient with LOPT diagnosed on support with BiPAP, participating in regular exercises will make it patient muscle weakness. Sorry, I didn't understand. What exercises? So the patient is on respiratory support, and I believe that there is BiPAP, so there has to be care for the lungs. I hope they are following up with someone, because in addition to the physiotherapies, which are very, very important, it is looking after the lungs, taking the vaccinations to prevent infections, to look after the bone health. There is a whole system of long-term care and surveillance and management. And so they have to follow up with the doctor. Dr. Gauri, you'd like to add something to that?
Not from a respiratory perspective. So as I mentioned with the ketogenic diet or diet with LOPD, so most importantly, I would make sure that they are on the high protein, aerobic exercise, low carbohydrate pathway with supplementation with antioxidants. So that I think would be the standard. Ketone precursors are not available, and the efficacy as well as safety data is just coming out now in some of the preclinical trials. So I think the standard response would be to enable aerobic exercise regularly, moderate to high protein intake with low carbohydrate intake, antioxidants along with everything else, and of course, if they're already on ERT, support for that.
So there is another question which is sort of associated with this, and there are two such questions. It is saying that is there any chances that of getting ERT free in India? And there is another question by Murtaza Kachwala, which actually says that my daughter's age is 15 and there's a diagnosis of LOPD. How can I avail ERT in Hyderabad? So anyone?
They should go to
like
the
ma'am?
COE there. Shankar, you
Yes.
please take those questions.
Yes.
Yes, actually, and now audible. I think there
Yes,
is no
sir.
echoing.
Yes, sir. Yes,
I
there's no
came out
echoing.
and they come
Yes.
back. Okay.
Yes.
So actually, ERT and LOPD, already I told you, ERT and LOPD, problem is you can approach to any of the COE and you can register into the COE and you can try ERT through that. But now the major limitation is the sustainability of ERT in a LOPD. That is during my talk I told. Because in a LOPD, if there is a 30 or 50-year-old, 50 kg weight, and in a COE, one lifetime financial support is 50 lakhs. 50 lakhs. But this in LOPD patient, in an adult, this 50 lakhs will last for somewhere around 4 to 6 months maximum, 4 or 5 months. So there is no sustainability. As we know, the LOPD, we have to give lifelong the enzyme replacement. So this COE support may not be a sustainable thing. So that is the reason most of the centers, LOPD, we are not starting treatment, because just we will start within 4 months, the enzyme amount is over. We cannot continue the treatment. So that is our major limitations, and government is doing some lot of discussions on this matter, but there are so many limitations to uh, enhance the limit or tell whether we will give a lifelong treatment, because as you know, it's a very huge affair. 63 diseases are there, so many conditions are having so many treatments. So that is a limitation, but definitely you should approach your COE, register in the COE, let them evaluate, let them register your case and kept in their record, so that at any time any possibility came, definitely you will get the insight. Second option is through the charitable access scheme, that I think now it is a little bit limited. Options are there. That also they will give for 6 months or something. More than that, they are not supporting most of the time. Only very rare cases they will support a long. So that is our limitations. We have come across a lot of, we have come again in a lot of, what you can say, nothing was there in 2007 or 8. From there, we have reached a situation where we can treat some of the patients, but everybody may not getting that benefit because of the limitation of the financial limit of the policy and other things. I think both questions are answered, and in Hyderabad, you have to approach the NIMS Hyderabad, which is the COE, and Dr. Ashwin, you can directly go to CDFD. But actually, the hospital and evaluation, everything is happening in the NIMS Hyderabad, Nizam Institute of Medical Sciences. Dr. Prajna and Dr. Shagun is there. You can contact them and you can approach them for getting the available treatment.
Shankar sir, we have one specific question for you. Is there any possible way to check urine glucose tetracycline as you have, this is a particular patient who had consulted you earlier,
Yes,
and he's
yes,
asking you about the urine glucose tetracycline.
I have seen that. So actually, that's I told. We are not regularly doing this urine glucose tetrasaccharide test. Even the patients on the enzyme replacement, we are not regularly doing it. Previously, I had some experience where we were using in the charitable access scheme. We have sent for this urine tetrasaccharide. So I don't have any directly, but Ratna madam can add if they are doing or they are sending somewhere. Ratna madam.
No, we are not doing.
Okay, okay. So I think it is not possible, but practically for the diagnosis, it is not required. Only during the treatment, how it is a prognosis and other thing they have recommended, but routinely it is not required for the diagnosis.
One last question to all the faculties from my end. So I'll just go like a rapid fire, and you can please add your thoughts and comments to it. So I'll start with Shankar sir because he was speaking. So Shankar sir, do you think newborn screening, like Pompe's disease, should be included? Like yes, no.
At present, no. In future, yes. Because
Okay, and
academically, definitely
yes.
there is a benefit is there. But at present, it is not the time, because we are not at the level of identifying Pompe disease and treatment, long-term treatment, so many other problems, etc. is there. So even other diseases, universal newborn screening has not come into in our uh,
In
country.
our
In our
in the front
country.
line. Yes,
So
yes,
definitely it should be in the one of the condition which we can include in the phase 2 or phase 3 manner, phase 2 manner.
yes. Ma'am, Ratna ma'am.
Yeah.
Ma'am, you are on mute. Yeah.
First, we have to make treatment available. The universal treatment available lifelong, not up to 50 lakhs. because you do newborn screening for early identification of disorders to treat them. So that is one. Secondly, the day we start doing universal newborn screening for hypothyroidism, and we have the system in place, okay? It's not a test, it's a program. And so we don't even have the infrastructure for this program. I think if we just look after, and I reiterate what Dr. Gauri said, that patients think that just getting ERT is sufficient. We have enough evidence in India that if we don't do multidisciplinary care, it's not going to help. We cannot expect a patient who's staying 500 kilometers from a hospital where therapy is available to have access to therapy. So we have to first build those systems before we forge ahead with doing newborn screening.
Right. The Ashwin sir, are you still there, or Ashwin sir? Sir is probably still not there. Gauri ma'am?
I mean, I agree with Dr. Ratna. There is, I think I said, it's been about 18 months since I've relocated, and this has been my biggest challenge in understanding how we can ensure that patients understand that there is no magic bullet. It's sustained, it's continuous, and as a system, we don't have everything in place to try and bring together a sort of a multidisciplinary approach, which is critical in chronic disorders and rare disorders. And lots of us work in silos, and I think it's really important to have days like this and have more discussions as to how we can improve framework systems, because that's how we can cascade into something that's more sustainable. And as Dr. Ratna said, has to be lifelong. So there's no point in doing some screening when we have nothing really substantive to offer at the end of it. And that's what we need to work at. And I think that, all of the work that all the other panelists have done over the years has been excellent. And I think going forward, we just need to have a cohesive strategy for rare disorders in order to try and ensure that it's not a policy that is very myopic, and it because they're living through to their adulthood. So we should be able to cover the whole spectrum from birth to death. And that's really important to think about before we enable any such things. Yeah.
Also, sometimes maybe develop the transition care. So some of the children
Yes.
who are receiving the ERT going into with the adults. Doctors, again, the awareness level and the way they are being treated over there. Yeah, there are some challenges there also. Thank you so much for being a part of this webinar at such a short notice. I will request Prasanna sir, who is here, to also say a few words before we conclude. And Prasanna sir.
No, I don't want to say anything, because we are all working with these doctors, and doctors are helping us and patient community from last over 20 years. Thanks for their valuable time. It actually went beyond 1.5 hours actually, but it is worth it since it is being recorded, and which will help many new doctors, patients, because a lot of people reach out to us saying that, okay, I would diagnose the Pompe, what next? I think when you send this link, it helps, and many doctors have expressed. And even last 1 year, 52 webinars we have completed, the Rare Info series, that we are compiling and creating one sheet so that it becomes a ready reckoner. They can click and go to any topic of their interest by any speakers. I think that's the kind of repository we are creating. I think this is a huge value addition and valuable asset to the rare disease knowledge bank which ORDI is trying to create. I just thank you so much, Dr. Ratnaji, Dr. Shankar, Dr. Ashwin Dalal, and Dr. Gauri. And last but not the least, Dr. Deepanjana for moderating. Thank you so much. And apologies for last moment push in a short time, but it come out very well. Thank you so much.
Thank you.
Thank you. Thank you.
Bye. Thanks.
Thank you.
Bye.
Thank you so much for all your valuable time, and especially at the last moment, thank you viewers for being there with us. And you can find this link, as Sir said, later to look on to the topics to learn more. And with this, we end today's webinar. Have a very good evening, and hope we could add few drops to the knowledge you already had. Thank you so much.
Bye-bye.
Bye.